Good evening, everybody. Thank you for the introduction. I have a warning. I enjoy interactive presentations, so I will have a few questions for the audience and I'll need a show of hands. And this is up and this is down because I'm a surgeon and I don't understand middle grounds. So if we can all play along, that'd be really good. So what I'm talking about is two different women with the same mechanism of injury. Okay, so as we've heard from Rose, this is our patient in the trauma service at Royal Melbourne Hospital, someone who's fallen from standing height. I should say that both of the cases, both the patients I'm going to present today, were very happy to have their clinical photographs used, and I think they tell a bit of a story. So I have put it in the missed format, which you can all read, but she had a fall. She's from a low-level care nursing home, and she was visiting her son on some day leave, kind of had a bit of a mechanical fall, bit of a slide down the wall. Felt okay at the time, so he took her back to the nursing home, and then later on in the evening it became quite clear that she actually did have something going on, and so the nursing home then called the ambulance, and this is what you can see here. So the first question I have is, what is her frailty score? So I don't know how well it's projecting. Basically you've got 1 to 9. 9 is you're dying. 1 is you are fitter than other people your age. Now, I don't know how many people in the audience would give themselves a 1, so for that reason, I'm going to break it up into 3. So people who think, based on that photo alone, is she a 1 to 3? Is she a 4 to 6? Or is she a 7 to 9? So I want hands, and I want them up. Okay, who thinks that L, the lovely lady we saw, would be between a 1 and a 3? So 3 is managing well, and 1 is very fit. Any hands? Oh, you're so cynical. Okay, 4 to 6. So 4 is vulnerable and 6 is moderately frail. 4 to 6. Okay. 7 to 9. I'm actually impressed. She's a 6. Well done. Okay, very good. So she had a frailty score at admission, which is when we do it, of 6. So, a bit more. We're having a Rose moment, right? So she's got vascular dementia, she has osteoarthritis, she's had reflux, she's already had a fractured neck of femur and managed to get to a low-level care nursing home, so maybe that actually says a bit about her too. That was 9 years ago. She's got depression, she's on an SSRI. I started writing out her medication list and I just stopped. But I think it's more important actually is her social history, right? So she's in a low-level care nursing home, she can't hear very well, and she's a bit doddery on her feet, and she has smoked her entire 86-year-old life, pretty much, in utero. So this is all she has, right? Reassurance time, okay? She has a single system injury, right? It's just rib fractures. There are only 4. I've got the recons there because I like them, because I use them, but that's another story. So that's her injury. That's it. I have another question. 4 rib fractures, smoker, 86 years old. Does anyone in the audience just want to have a guess, ballpark figure, what's their inpatient mortality risk? You can shout it out. No one's shy here. We're all working at Royal Melbourne or come to visit us, so. 75. Oh, the cynicism, I like it. Anyone else? 56%. Ooh. I feel like we're in a reverse auction. Yeah, okay. All right. So, unfortunately, we don't have a really accurate way of working this out. But what Bolger et al. Did is they only looked at age and number of fractures. Okay, so that's what you can see here. They didn't bring into it frailty or smoking status. And even with that, as you can see, every additional rib fracture you have, if you are over 64, increases your inpatient mortality risk, your 30-day mortality, by 19%. So based on that, so she had 4 ribs, if you draw it across, like 20%-ish, 20% or so, okay? I think it's going to be higher, I'm with you, because she's frail and she smokes. But raw numbers, that's 1 in 5 of these patients, just like Elle, who are not going to go home. Actually, it's even more who won't go home. It's people who won't leave alive. Pneumonia, everyone's favourite. So she, based on the ribs, not based on the smoking, has an inpatient risk of getting pneumonia of 30%. And once again, what they showed in this paper was every additional rib increases your risk of pneumonia by nearly 30%. So if you initially had a 10% risk, you get another rib, 13. So she got admitted under the trauma team to the Jerry's ward. She wasn't seen by the trauma team in ED. When the team reviewed her, they charted her up for some analgesia, some DVT prophylaxis. I'll talk a bit about that. shortly. This is all depressingly predictable. So she had oral analgesia, not all that much regular, quite a bit of PRN. On the second day, she had a met call for decreased GCS, because you might remember she had quite a few comorbidities, and she was on a combination of her usual SSRI with Targin. She also had, I think, a bute patch, and she had some PRN morphine. And so all of that combined, we looked into other causes, but we worked out that actually would probably narcotise the patient. And in that setting, the decreased GCS, losing the respiratory drive, pneumonia developed the next day. Once all this has happened, hypoxia is bad for brain function, as we all know, and so it makes it really hard for people to engage with physio and OT when they can't think straight because they've got pneumonia with their horrible rib fractures for which they're receiving analgesia. So she couldn't really engage very well. She ended up getting transferred to the medical team on day 7, and on day 16 she went back to her nursing home. Frailty score of 6. I'd like to introduce you to someone else very soon. Before that, this is a busy slide, but basically what this is saying is that everything is in a big circle of badness for these patients, so they come in with pain. We need to treat that in an appropriate fashion, because if we don't, they don't breathe. People who don't breathe get pneumonia. They cough, they get confused, and they're not engaging with what they need to be doing. They get drowsy, they're not going to get fed, then you've got malnutrition on the top, then the analgesia plus the lack of normal diet plus the not mobilising means that the bowels go off, which means that it all just keeps going. And it's really important to intervene so that this doesn't become a vicious cycle and it stops somewhere. But this is G. She's 89. She also fell from standing height onto her right side, and the ambulance was called again. Her vital signs on scene were normal. Again, she was given some analgesia and some oxygen. So we're going to play the game again. Okay, does everyone remember what she looks like? Yeah? All right, so I'd like some hands. 1 to 3. Oh, look at all the positive people. It's changed, okay? 4 to 6. 7 to 9. Oh, I'd hope not. She's a 2, so well done. See, and what's really interesting, right, in an N equals 2 environment, is that the majority of people are able to pick from a single clinical photograph taken on day 1 of admission a ballpark of how frail someone is. So it's actually not that difficult. You just need to look at people. Anyway, you can see she has comorbidities too. Her type 2 diabetes is managed just with oral sorry, she's not even oral, she's just diet controlled. So I think from memory the chronic renal failure is hypertensive nephropathy. She lives alone, she's fiercely independent, council gives her some help once a fortnight, and she does her own cooking, thank you very much, and she likes the food that she cooks. She has 6 rib fractures. 6. I don't know if anyone can remember the slides from before about the mortality risk for that, so I put it again somewhere. But we'll check. 6 rib fractures, non-smoker, and she's 89, so she's even older. So does anyone want to give a ballpark mortality? 6 ribs, 89? 50. Oh, wow. Anyone else? Getting closer, yeah. So she's up. So she's like 25 or so. And again, we remember, increase all comers 19% if you're an elderly patient. Every single rib that you add on, increased mortality 19%. And pneumonia, so her pneumonia risk was sitting up nearly 40%. Okay, so that's huge. That's 2 in every 5, 4 in every 10. It's a lot of this room if we were over 65. So she was seen by the trauma team in ED. She had PCA started. She had oral analgesia along with it. Renally adjusted. She also had DVT prophylaxis, and a referral was made when she was admitted for chest physio. She was getting there, still a bit sore, didn't have indications for rib fixation, but she wasn't as confident as she used to be, and so on day 5 she went across for some rehab and she went home, back to her home on day 14. So these are the 2. Frailty 2, on everyone's right, frailty 6 on the left. So I think this highlights to me a number of issues. 1, the importance of frailty, which I feel certain we're going to hear a lot about tonight. 2, low falls are bad. Okay, we kind of same as ribs, I think. There's a kind of, yep, it's just a low fall. It's not a big mechanism. It's not a big deal. But it kills more patients that we have here than anything else does. Third is analgesia in elderly patients and how difficult or nuanced that can be, and the importance of multimodal analgesia and thinking about comorbidities and thinking about the best method of delivery for your individual patient. And I actually think the other thing that's really important is bundles of care. So that idea that if you can have a tiny little incremental gain from a few different things and you put them together, and potentially that makes a difference to what we're doing. So I have some take-home messages because it's me, and that's that biological age does not correlate to physiologic age. I would say that we surgeons sometimes say once you operate on someone, they do declare themselves as actually being 90, but up until that point when they're coming in with their rib fractures, it's really different. The patient who's managing at home, doing her own cooking, versus the one who's in a low-level care nursing home, trouble getting around, already fractured a hip before. And the other thing I'd really like to hammer home is that there was traditionally quite a bit of nihilism, I think, around rib fractures, because you felt like you couldn't do anything and you felt like it didn't matter anyway, because they'd all get better. And I think that the studies that we have, the information we have, reminds us that it's actually a big risk of mortality for those patients and significant morbidity. And so we need to take them seriously and recognise that fractured ribs in old patients who then are smokers and everything else makes them a high-risk group, and that means that they deserve early intervention. So anyway, they're quite cute, that old couple. Any questions are at the end, I think, aren't they? So that's it. Not all 80-year-olds are the same. You can make it better, and sometimes they can even get home, just like Rosa's patient. Thank you very much.